with it. For us as ophthalmic surgeons, we know that positioning this patient is very difficult. The same patient I showed you, so you give a block with this head propped up like this, you have to put pillows over here. My nurse is standing on one big stool, and then I'm also standing and doing phaco because you put 1 foot on the phaco machine and so on. It's quite a lot of athletic gymnastics to get a good outcome for these patients. So you really want to, so these are some of the cases where you get them well controlled and try to operate before the cataract becomes very hard. So these are some of the difficulties that we face in HLA-B27. Coming to the next scenario, that was, HLA was, if I said was a commonest, then this is probably missed or misdiagnosed. So this is a 24-year-old, sudden vision loss with a white reflex since 3 weeks. And he says there's no history of trauma, he never had a red eye, and otherwise was absolutely fine, and suddenly his vision went down. So anybody else, like previously somebody yelled out with the correct answer here? Okay, nobody is interested. So I'll add further that he had these fine medium to large size scetic precipitates which were going above the midline also. So young patient, no history of redness. Look at how nice his iris edge is, the pupil is, no posterior synechiae, and suddenly a cataract. Yeah, please, one person say it loudly. Yeah, exactly. So if you look at the iris, you can see that there is some depigmentary or looks a little brownish for Indian, we generally have blacker irises, deeper irises than this. So there's nothing but a case of Fuchs heterochromic cyclitis. So it looks like you're not going to misdiagnose. But believe me, when the patient comes to you in clinic, without this classical picture, you might still start the patient on treatment. You might work up the patient completely. It's fooled the best of specialists here. So this patient comes with a Dumescent cataract, and he has this fine medium-sized KP, as I said. So what do you do for this patient? You can definitely offer cataract surgery. The outcomes, so if a patient comes with uveitis, and it is Fuchs uveitis, and they have cataract, so I try to put a flip side and say that if you had to have uveitis, this is the best uveitis that you could have had. Because you're going to get better, you'll have complete vision recovery, and you'll hardly see any of the other complications that we associate with uveitis. And I need to keep seeing you once in 6 months to a year, and you don't need long-term therapy. So if you put it in correct perspective, this particular disease has an excellent outcome in terms of prognosis for the patient. Why it happens? So some more patients, 36-year-old, was being treated for a long time as intermediate uveitis because Fuchs also has vitreous opacities, and it very closely resembles granulomatous uveitis or intermediate uveitis. Another patient who had mainly the vitreous opacities and as a frequent feature, and this patient had undergone multiple testing for various diseases, had even gone into depression because he was told that you have a disease which will not improve and you will go blind. So there's no need to do that. So that's why it's often either overtreated, misdiagnosed as something else like intermediate uveitis, for example. And this treatment is fairly simple. Really, you need to do nothing. It is presumed to be due to the rubella virus. It's probably due to the rubella virus where we develop antibodies and reaction in the eye due to that. We don't know how to completely eliminate it so far. We use antivirals, it doesn't seem to work. So that was about Fuchs, probably very often missed. But you guys are very intelligent, you've picked it up. So let us see if you pick up this next scenario. This is a 35-year-old lady who came with recurrent episodes of redness since 16 years. So that's the feature now, the long-standing. She was diagnosed elsewhere as Postular-Schlossman. Incidentally, she underwent LASIK and cataract surgery. That was okay, she had good vision recovery. But when she came to us, one eye was extremely good, but the affected eye, where she had recurrent redness and Postular-Schlossman syndrome, her vision had dropped all the way down to counting fingers vision. In a broad slit, because she has undergone LASIK, so you have something called interface fluid, which she has. You can pick it up on the OCT. So those of you who are interested, so this is the anterior part with the epithelium, as well as a LASIK flap right in this section here. And this is the interface fluid due to high glaucoma. And look at what is hanging on the back. So these are those cheritic precipitates. So she has fairly large cheritic precipitates, very discrete and kind of white. So her pressures were 42, and she had almost 0.9 cupping. So any takers on the diagnosis here? Again, somebody said it. So what is Postular-Schlossman syndrome now renamed as? One person can see it. Okay, but what is it, the etiology? Is it immune-mediated? Is it tuberculosis? We have TB man over here. Okay, so I'm glad, something I can say. So this is very classical of viral. So now all the Postler, Schlossman, we just rename them. We call all of them as viral anterior uveitis or viral ketouveitis or viral endothelitis. But it's basically the etiology is viral. It's in the anterior segment. Typically, again, you saw the pupil was nice and round. You don't have posterior sine K, except you can have it say, in VZV. But in CMV, you have this typical history of long-standing disease in a younger patient. So there are, won't go into great detail, but what we did for this patient is we did an AC tap because we have access to a very good lab, and they found out that the patient has very high copy numbers for CMV R gene, and we treated the patient with VAD-ganciclovir, which is the treatment of choice for CMV, and the patient actually did extremely well. All that inflammation disappeared, that interface fluid I described to you, the pressure came back to normal, all disappeared. Only thing is that her vision was affected due to advanced field loss. So we had to do a trab also for her to protect the remaining optic nerve that she had. So 3 viruses can cause well, there are probably many viruses. The commonest 3 are CMV, VZV, and HSV. They have a little difference in their presentation. Sometimes they look very similar. So long story short is that what you can do is whenever you see a patient with recurrent uveitis with secondary glaucoma, increased intraocular pressure, just rebill it in your mind as it's viral. If you don't have AC tap results available, you can simply start the patient on acyclovir because it's cheaper. And then if it doesn't respond, then you might think whether you want to start the patient as a second line on ganciclovir. I'm simplifying it a lot, but that is just in a summary. So as I mentioned earlier, we finished pediatric uveitis. Hopefully you were listening. And also, as I said, that the last part, which was about masquerades, is very, very rare, and which is why I'm not going into it today's presentation. So thank you very much, and thanks Abhilasha and TOS for this opportunity.
So Dr. Somshila Murthy, are you saying that for every patient who has uveitis with raised IOP, it should be as a protocol, antiviral should be started?
That's a good question that Malika asked as usual. Not every patient with raised IOP. So patient with recurrent anterior uveitis with particular discrete looking keratic precipitates which do not respect the midline. So you don't have distribution of the KPs in the Als triangle, but you have diffuse KPs, maybe medium, maybe large. And this kind of patient has recurrent inflammation as well as at the time of inflammation has increased intraocular pressure. So this particular entity without too many posterior sine K and so on. So with all of those conditions apply, that entity is viral anterior. Because otherwise in uveitis, as you correctly pointed out, you can have secondary glaucoma to many reasons, steroid responsiveness, angles being closed and so on and so forth. But in this particular way that I've mentioned, that will put it into the viral bracket.
Okay,
Yeah,
so
good thing you asked.
So you would have followed up the patient a few times with recurrences before you reach that decision to start antiviral?
Yes.
Or there should be a history at least of
Yes and no.
recurrent.
So earlier we used to do that. Now if I have a patient walking in with these features, clinical features, I immediately label this as viral. I don't even investigate now.
If I may add, it's a viral anti-uveitis is a disease of 2 P's. One P is for pressure and the other P is for pigment. So pressure we have already discussed, the other P is pigment. So you see a lot of pigment in the anterior chamber, you see pigmented keratic precipitates, typically central pigmented keratic precipitates. And you see loss of pigment from the iris. So you see sectoral iris atrophy, which is very well seen on transylvination. Then you know that you're dealing with viral anterior uveitis, typically the zoster or simplex. CMV is a different ballgame, and Somshila nicely discussed that part.
Any questions from the audience? Okay, so we'll go on to the next.
Our next speaker is the convener of the meeting, Dr. Abhilasha Bahrani, and she's going to speak on intermediate uveitis.
I thank the scientific committee of TOSCON for giving us this opportunity. So I'll be presenting 5 diagnostic pearls for intermediate uveitis. So intermediate uveitis by definition is inflammation where the vitreous is the main site of inflammation with an absence of choroiditis or retinitis. So this is the basic thing that we should be kept in mind when making a diagnosis of intermediate uveitis. So this is a young male, one-eyed patient. We see a lot of snowball opacities, and we see a chorioretinal scar underlying a blood vessel. So the first pearl is trying to look for clinical clues, because many of the times when you try to investigate, the investigation may not come out to be positive for anything, or the investigation may come out to be positive for something that you were not expecting. So it is better to look for clinical clues when you see the patient. So this patient, as expected, had a positive Monto and HRCT changes of Cox on the chest. So this patient was started on anti-TB therapy, and this is how he healed. So here the clinical clue was the sclerosed vessel with an underlying scar. Now this is another patient with a similar picture, but fewer snowballs. Okay, there are fewer snowballs, and you see these depigmented patches in the periphery. So this gives a clue towards sarcoidosis, and here Monto is negative, there is lymphopenia, and there are bilateral hilar lymph nodes on CT chest. So this is, so before even investigating, you have a diagnostic clue in your mind. Now again, you see this patient with dense vitritis, and here you see a string of pearls vitritis. So this is again typically described for sarcoidosis, and when you closely look, you can actually pick up these clinical clues. You have to spend time with these patients. Again, even if it is a case of anterior intermediate uveitis, you may see some anterior segment signs like broad-based posterior synechia or peripheral anterior synechia. Now these broad-based posterior synechia are usually seen in TB uveitis, and peripheral anterior synechia or angle KPs are seen in sarcoidosis. So in our country, the most challenging thing is differentiating between these two entities. So we must keep in mind that TB presents with broad-based synechia, sarcoidosis with peripheral anterior synechia. Snowballs are more common in TB. String of pearls is more common in sarcoid. Pigmented scars, more common in TB, depigmented in sarcoid. Of course, Monto is positive in TB. Monto may sometimes be negative in sarcoidosis. Lymphopenia, we often do complete blood count, but we do not pay attention to the values. So please see the lymphocyte count. Dry eye has been described as a feature of sarcoidosis, and sometimes these patients present with hypertensive uveitis. We must all acquaint ourselves with HRCT findings in these patients, like you see more of fibrotic changes, calcific granulomas in TB, and you might see pleural nodular thickening and intra or interseptal nodular thickening in sarcoidosis. So you can read up all these features, and if you have friends in the radiology department, please discuss with them. They will give you a lot of clinical clues about these patients. Now the second pearl is, you should see whether the inflammation is active or not. So these are two eyes of two different patients who were referred to me as cases of uveitis. So these patients probably had pars planitis in their childhood, and they were treated with cryolaser, and now they do not have active uveitis, but the patients were very anxious because the doctor told them that you have uveitis and it is a blinding disease. So these lesions are not active inflammation, and you can also get clues when you do the OCT. There is no thickening of the choroid. So again, those two pictures, and now this is active uveitis. You can actually see that the fundus is hazy. So this is how you should differentiate and not unnecessarily treat patients who do not have active inflammation. Now, pediatric intermediate uveitis is an important clinical entity. In these patients, intermediate uveitis is often associated with disc edema, and these patients should be started on immunosuppression early, because if you treat them with steroids for a long time or give intravitreal steroid injections, they have a propensity to develop cataract, and it's not good for children if they get early cataract. So we must try to keep them on non-steroidal anti-inflammatory therapy. Now, beware of imposters. This patient was referred to me as a case of intermediate uveitis. He had CME, but if you take a closer look, the haptic of a single piece lens is in the angle. So this is actually an Irwin-Gass syndrome, and this patient required explantation of the IOL and SF lens. So this is not uveitis. Again, Fuchs' uveitis often is confused with intermediate uveitis. Now here you don't see the typical snowballs, you see more of vitreous opacities, and of course in the anterior segment you see stellate capes like Dr. Somshila showed, and you have often you cannot see the hypochromia of the iris clinically, but if you take a photograph it is more easy to differentiate. Toxoplasmosis, if you don't examine the periphery, sometimes we may miss toxoplasmosis, especially when there is dense vitritis. Now this patient has a very dense vitritis, but when you see the periphery, you can see a whitish lesion. So these toxoplasmosis patients also, it's better to take photographs and then try to analyze. Another case of old vitreous hemorrhage, which looked like intermediate uveitis. Acute retinal necrosis often presents with dense vitritis, and this may be mistaken for intermediate uveitis if we do not examine the periphery, and these patients need specific antiviral therapy. VKH, many times I see patients who are treated with low-dose oral steroids, and when they come, they have few cells in the vitreous, but when you do the OCT, you see a boggy choroid and RP undulation, and you know that this is not intermediate uveitis. Behçet's disease is another, where sometimes the retinal infiltrates may be in the far periphery, and you might just see cells in the vitreous. And here, if you see, this is a retinal infiltrate. This is not a snowball. It is on the surface of the retina, and these patients have to be treated very aggressively. Leptospirosis is another specific entity which does not show many fundus findings, but it presents with typical vitreous membranes. And when you see these vitreous membranes along with vitritis, these patients should be investigated for leptospirosis and treated accordingly. This is after treatment. Now, the fifth pearl is vision-threatening complications. So, cystoid macular edema is the single most common cause of decreased vision in intermediate uveitis, and you can see this typical flower petal appearance on FFA, and this can be followed up on OCT. Peripheral neovascularization, sometimes patients who have prolonged inflammation develop new vessels in the periphery, which may lead to neovascularization and vitreous hemorrhage, and this has to be treated. Glaucoma, sometimes we are very busy grading the cells and looking for snowballs. We forget to see the disc, and in this patient you see there are snowballs floating in the vitreous, but there is a clear-cut inferior notch here, and you can see the RNFL defect, and which is confirmed on visual fields. So glaucoma should not be missed in these cases because we might control the inflammation, but patient may not retain vision because of glaucoma. ERM is another complication which needs vitreoretinal surgery. Sometimes in dense vitritis, a macular hole may be hiding there. Sometimes you see this OCT picture, try to, wherever possible, try to do OCT in all these patients. And here, we know that this is not a CME. And when you control the inflammation, you can see that there is a CNVM hiding there. So these conditions need specific treatment. So in summary, look for clinical clues. Investigations are not always conclusive. And when you look for clinical clues, you will know what to order, what to advise. Determine if inflammation is active before starting treatment. In pediatric cases, start immunosuppressive therapy early and avoid local steroids without an etiological diagnosis, and rule out all the differential diagnoses and look for sight-threatening complications and address them appropriately. Thank you. I'd be happy to take questions.
Any questions from the audience?
think, the point to remember on intermediate uveitis, it's that it's very commonly overdiagnosed. So you nicely brought about some of the conditions where intermediate is overdiagnosed. I think Fuchs is the one that is most commonly overdiagnosed as intermediate uveitis, because all these people have dense vitreous floaters. So more than the granulomatous anti-uveitis that you're seeing, it's the floaters that will lead to intermediate uveitis, and if a MON2 or something comes positive, then TB, and it goes in that direction, whereas it doesn't really need any treatment. Similarly, if you don't look carefully at the posterior segment, we'll miss out the toxoplasma or the acute retinal necrosis, which are very common causes of dense vitritis. In general, it's not a hard and fast rule, but if the vitritis is so dense that the fundus is very hazily seen, then it's very unlikely to be intermediate uveitis. In intermediate uveitis, generally the fundus is seen reasonably well. So, we should be very careful when the vitritis is dense.
Agree. And over-treatment with anti-TB medication not required. Most of the time you can leave without treatment if patient is negligibly symptomatic.
Thanks, Abhilasha.
Thank you.
Next, we'll go on to Dr. Malika.
Malika.
You're next.
So I'd like to thank Dr. Abhilasha Barani for this opportunity. I'll be speaking on posterior uveitis. So the posterior uveitis can be classified as per the IUSG as choroiditis, chorioretinitis, retinitis and neuroretinitis. But we know for practical purposes that we also see retinal vasculitis, which can be included. Again, as per the IUSG, it is infective, non-infective and masquerade. But we have a very large group where it is not really infective, but it is somehow it is immune mediated by exposure to tuberculosis. Now, what are the diagnostic pearls for posterior uveitis? First of all, we should try to understand whether it's the location of the disease, posterior or peripheral, whether it's localized or extensive, whether the patient is immunocompromised, because that means it could be infective, whether the patient has pain, because posterior uveitis in itself is not painful unless it is associated with posterior scleritis or there is significant iritis. Otherwise, it should not be painful. Associated ocular features and associated systemic features, very important, and the history of the patient. These all give an idea about the etiology and classification. So systemic features are skin rash, nodules, painful nodules, vitiligo or alopecia, which you can see, history of fever recently, any interventions, septic foci, arthritis, lymph nodes, if there is a history of lymph nodes for which they are getting treated or investigated, history of TB or exposure, and travel, recent travel. So this is how you can have some idea. Peripheral retinitis predominantly will be ARN. Posterior pole is usually toxoplasmosis or candida, also CMV. If there is presence of significant vitritis along with the posterior uveitis, then it's more likely to be toxoplasma or ARN, also endogenous endophthalmitis, sometimes TB and Lyme. So as I said, pain, if there is, this was a patient who presented with, we thought neuroretinitis and panuveitis in the left eye, but actually the severe pain was explained only because he had posterior scleritis. And then to know if there's posterior scleritis, B-scan is very good, chorioretinal thickening, retroscleral fluid, optic nerve shadow enlargement, and also the OCT will show, in a case of retinitis, if you're getting choroidal elevation, it's because of scleritis. Serous detachment of the macula. History, very important for fever. I will not read out the diagnosis, but fever or IV injections, tick bites, pets, contact with animals, rural habitat, agriculture. This is an eschar which can be seen in a tick bite causing rickettsial disease. Oral ulcers, very important. We missed in the last patient I showed. We did not think of syphilis for a long time. Oral ulcers, genital ulcers, history, skin nodules, immune status, post-transplant immunosuppression, diabetes is immunosuppression, HIV. Very important is skin rash. If there is, so these are the various. One thing to understand is not all skin rash is viral uveitis. It could be SLE, or more importantly, it could be other infections like syphilis, rickettsia, Lyme, leptospirosis, which are always missed. So not all retinitis needs antiviral. Think of the other diseases which have a specific treatment, doxycycline, fluoroquinolones, which immediately clear out the uveitis if we have thought about it. And especially fleeting rash, if the patient says the rash was moving within hours from one part of the body to other, then that is very likely rickettsia or Lyme. Also adult onset Still's disease, a type of SLE. Lymph nodes, skin nodules, eschar. Now this type of a patient, for example, if you see bilateral cotton wool spots with or without occlusive vasculitis, then this is SLE, very likely to be SLE. And periphery can have non-perfusion with new vessels. This is again an SLE type disease, which was resolved on steroids. This is a single lesion on the posterior pole with or without vitriitis, toxoplasmosis, with or without a scar, pre-existing scar. Again, a creamy white lesion on the posterior pole. This does not look like toxo. This is more likely to be candida and may be associated with vitriitis as well. Again, another patient, creamy white lesion on the posterior pole, candida. Now, important thing with candida is many of them are immunosuppressed. And this, if you see in a severely immunosuppressed patient, is aspergillus. Kind of extensive retinitis, not a single candida lesion, and very severely immunocompromised patient is aspergillus retinitis. Again, an immunocompromised patient with aspergillus causing CRAO. This is a CMV retinitis, immunocompromised patient, cottage cheese with ketchup appearance, extensive with hemorrhages, and suggests immunosuppressed status. This is again an immunosuppressed patient, but deep retina is involved, so it gives an appearance of cracked mud. And this is progressive outer retinal necrosis, bilateral causing optic atrophy and blindness. Now, if you have this scalloped edges in the periphery, unilateral or bilateral, patient may not be immunocompromised, then this is ARN, acute retinal necrosis, with or without severe vitriitis. Sometimes ARN can present with posterior retinitis and can be missed because we keep thinking it should be peripheral. And also sometimes it may be having severe anterior scleritis, and so we totally miss the retinitis, busy treating the scleritis. So be very careful, look at the entire retina. This is dengue retinitis. There would be a history of prior fever 1 month prior to the retinitis. And very typically it may resolve with dengue fovealitis, which causes poor vision and optic atrophy. Now if you have retinitis in this way, retinal abscess rather, unilateral or bilateral, patient may be immunocompromised, though sometimes not. There would be a history of fever with intravenous injections or septic foci and procedures done recently, endogenous endophthalmitis. Very important, if you see white lesions on the retina, suspect rickettsial retinitis over the posterior pole. Now this patient received several injections of antivirals and oral antivirals because there was a history of skin rash as well. So we also spent a lot of time, wasted time with steroids, but on taking a history, we realized there was a fleeting rash. And that led us to the diagnosis of rickettsia. A fleeting rash happens in these diseases. So we investigated for those 3 diseases, and Weil Felix was very strongly positive, which suggests rickettsia. So this patient responded to doxycycline very well, which for months he was not responding to antivirals and steroids. Sometimes TB can cause retinitis, though mostly it is choroiditis, and responds immediately to ATT. Now this was a very interesting patient. We missed the fact that he was complaining of ulcers in the mouth, ears, genitalia, and we treated him with severe pain also. So we did go around and finally reach the diagnosis of syphilitic uveitis. His blood tests were negative. As soon as we gave him treatment for syphilis, he resolved, IV ceftriaxone. But another important thing is pain could not have been from neuroretinitis and panuveitis, and that was because of associated scleritis, which was syphilitic. Now I come to the second large group of posterior uveitis, which is choroiditis. Choroiditis, unlike retinitis, is more often non-infective. Less often infective, which can be fungal or TB, and most commonly, in fact, is TB-associated immune-mediated uveitis, choroiditis. So one of the common things we see is non-infective multifocal choroiditis. Patient comes with sudden blurring, no pain, white eye, and then sudden vision drop, unilateral or bilateral, responds magically to steroids. Similar this patient, but they can also have recurrences which may respond to steroids. This is again non-infective choroidal granulomas, which are sarcoidosis. Then you have infective ones. This is a patient who came from traveling from South America, endemic to blastomycosis. He had a lymph node biopsy done, which showed blastomycosis. So we already had the diagnosis, treated like a fungal choroiditis, resolved. So history is very important. Here, if you have coin-shaped lesions, patient is asymptomatic but immunocompromised. This is pneumocystis carinii in an AIDS patient. Does not need any treatment because they would be treating for pneumonia as well. Now sometimes there can be actual tubercular infection in the eye, as in this patient. COVID unmasked his AIDS and he had this. Or in this patient, you see tubercular macular lesion with healed lesions in the inferior mid-periphery. And as soon as we started his ATT, this disappeared, resolved. Similarly, this patient, we missed the diagnosis. We thought it might be endogenous endophthalmitis. His tests were negative for skin test, but TB Gold was positive. However, we treated him like endogenous endoph, but he continued to get new lesions till we started him on ATT and with complete resolution. This is again a TB granuloma in an AIDS patient, which continues to grow despite ATT. So when we confirmed with biopsy that it was TB, then we realized it was multi-drug resistant TB and responded to MDR regimen, 7-drug. So sometimes it may not respond even if it's TB, then it might be MDR TB, multi-drug resistance. Now we come to the most important group, which is TB-associated uveitis, but it's not TB infection in the eye. So we give this patient, this is how we learned, this is 10 years back, we would give steroids, we would give more and more immunosuppression, and patient continues to get new lesions. So what's the reason? Sometimes the tests are negative. TB Gold may be negative, skin test may be negative, but in frustration, we started anti-TB therapy with great result. Similar patient, multiple recurrences resolved only on anti-TB therapy. Similar patient responding only on anti-TB treatment with or without positivity of Mantoux or TB Gold. And this is the last slides. So sometimes this looks like a choroiditis, and you may have to resort to certain investigations. Like this patient looked like a central choroiditis, but the angiogram fluorescent angiogram shows multiple pinpoint leaks with pooling in the late stage, which is typical of sympathetic ophthalmia and not. Choroiditis has a very featureless appearance on fluorescent angiogram. And lastly, the retinal vasculitis, which can again be treated or diagnosed in the same way as retinitis. It could be infective, non-infective, and many times TB related. The only difference from retinitis choroiditis is it can lead to proliferative retinopathy with complications of hemorrhage and retinal detachment. Thank you.
That was almost like an atlas of posterior uveitis, and you have covered all the diseases extensively, ma'am.
Thanks a lot.
Any questions from the audience? So we'll move on to the next talk by Dr. Soumya Basu. Dr. Basu is an eminent uveitis specialist in Hyderabad, and he heads the L.V. Prasad group of hospitals for uveitis.
Good afternoon, everyone, and thank you, Dr. Abhilasha, for inviting me to this session. The audience is very gratifying. I don't think there are many sessions where we have so many people sitting like this. Thank you so much. So I'm going to talk more about how to test rather than what to test, and let's get started. So what we'll cover is why do we test in uveitis, because somehow, at the back of our mind, we always think that uveitis means ordering a bunch of tests. then how best to use this test, and a concept called as pre-test probability. In fact, if there is one word that I would want you to take from this small 10-minute discussion, it would be the concept of pre-test probability, and you are going to hear it again and again. What I'm not going to cover is the uveitis workup, because we try to stay away from this kind of approach, that any patient coming to you, you just order a bunch of tests. We try not to do that. So we'll try to discourage that. And if you want to know more details about these concepts, what I'm going to talk, especially the residents and fellows and young ophthalmologists here, I would advise you to go through this paper. For me, it's just 3 or 4 pages, not a very big paper. It's in AJO 2013. But for me, this has been the Bible. You know, I must have read it at least a dozen times, but each time I read it, I find something new to understand in this particular paper. Okay? And if you are interested a little bit more, you can go through this more extensive paper, which was published in Survey in 2021. So why do we investigate uveitis? Now this is, you know, the why is very important, because many common forms of uveitis actually can be recognized by clinical pattern alone. You don't have to do any test for them. And this includes many of the infectious uveitis. Most of the retinitis entities, including ARN, toxoplasma, all these are clinical diagnoses. You don't need a blood test for them. Okay, except the syphilis or Bartonella, you don't need any blood test for any of the retinitis entities. Viral anti-uveitis, which we discussed earlier today, is a clinical diagnosis. Fuchs uveitis syndrome is a clinical diagnosis. All of these are very, very common in practice. Similarly, amongst the non-infectious entities, white dot syndromes, VKH, Behçet's disease, and to an extent even HLA-B27 is a clinical diagnosis. The B27 is only to confirm what you are suspecting, but you know, up to 20% of these patients may have a negative test. So the test is really not that important. So the reasons why we investigate uveitis are for 2 important reasons. One is to rule out or rule in an infection. Ruling in, the most common example is syphilis, okay, that you do the test, it comes positive, you know you're dealing with the infection. And the other thing why you do a test is to rule out a systemic disease. And the best example here would be sarcoidosis, okay. You can't diagnose sarcoidosis without doing the test that is required for it. Otherwise, you may also need to do tests for getting the baseline parameters or for monitoring treatment response. Now, when you want to know how good is the test that you're doing, there are 2 questions that you would want to ask. If the disease is present, will the test be positive? And if the test is positive, is the disease present? Now, can anyone from the audience say which of the 2 questions is more important in your practice? Anyone? Second one. I think I heard someone say the second one, because, you know, on the face of it, the first question might seem more relevant, but the patient is not coming to you with a disease. The patient is coming to you with a blood test or any other test, radiological test, and you want to know if the test is positive, then is the disease is present. Now the statistics that will tell you the answer to the second question is actually called as positive predictive value. And the answer to the first question is sensitivity. So while we keep talking about sensitivity and specificity, when you're sitting in front of the patient in the clinic, specificity and sensitivity do not have much role. What really has a role is the positive predictive value. Now take a look at this scenario. There's a patient with 34-year-old male non-granulomatous anti-uveitis, acute onset, unilateral, everything suggestive of B27. But you have ordered a bunch of tests, and incidentally, the TPHA test comes out to be positive, and it has a very high sensitivity and specificity rate. So do you think that the patient you're dealing with has syphilis? Unfortunately, no, because it does not mean that just because it has a 99% specificity that the patient is having the non-granulomatous anti-uveitis due to syphilis. Instead, if we consider that the prevalence of syphilis in acute, recurrent, alternating, non-granulomatous anti-uveitis is only 1 in 10,000, then the positive predictive value of your positive TPHA test is only 1%, which means that despite having a positive test for such a good test in this patient, it really means nothing in this case. I'll just rush through it, otherwise I'll probably take over everyone's time. But basically this means the concept of pretest probability, which gives you the prevalence of the disease, comes from the ocular signs, the patient profile, the immune status, while other things such as a low prevalence, opposing ocular signs, or a patient profile which is not fitting into your diagnosis will lower the pretest probability. Now take this example. This is a patient with retinitis. You can see the bright yellow lesions at the posterior pole, and he had decreased vision in the right eye since 2 months and in the left eye since 1 week. Now you look at the OCT scan running through it, you see a full thickness retinitis lesion with a choroidal involvement. And when we found the picture from 2 months ago, we saw that the patient still had retinitis 2 months ago, and you see the choroidal involvement there too. Now, with the choroidal involvement and the full thickness retinitis, our main suspicion was toxoplasmosis, even though it was not fitting into the classical picture of Toxoplasma retinochoroiditis. But based on the clinical picture, we started the patient on oral cotrimoxazole while getting a test for TPHA and HIV, because syphilis is the other thing that could have probably caused a retinitis picture like this. Ask the patient to come back in a week's time. In a week's time, with that oral cotrimoxazole, you can see that the lesion has been resolving very well. It's staring at you. But the TPHA comes out to be positive, even the HIV is positive. Now what do? Do you switch over to treatment for syphilis, or do you continue treatment for toxoplasmosis? We decided to continue the treatment for toxoplasmosis while referring the patient for a treatment for syphilis, because the VDRL also came out to be positive. So with the positive HIV and positive TPHA VDRL, most likely the patient was having active syphilis, but what was happening in the eye was unrelated to syphilis, and it was responding to cotrimoxazole or Bactrim. Now this is the concept of pretest probability. Even if your test is positive, you go by the pretest probability of the condition and treat accordingly. This was the situation in the left eye, and you can see the lesion there, and it resolved. So how do you convert pretest to post-test probability? Now this, as I discussed earlier, it depends on the history, the clinical signs, and the prevalence of the disease in the area. And the way you get the answer is by a statistics called as likelihood ratio, which combines the values of sensitivity and specificity. Now I'll show you an example with the quantiferon TB Gold test, which from an Indian study has been calculated to have a likelihood ratio of 3.42. Now I'm going to give a table. Don't worry about all the numbers that you're seeing there. It's called a Fagan's nomogram, and the line that you're seeing on the left is the pretest probability. The line you're seeing on the right is the post-test probability, and the middle line is the likelihood ratio. Now, since we have calculated the likelihood ratio for quantiferon TB to be 3.42, we place a dot there, and in a situation of non-granulomatous antiuveitis, if we think that the pretest probability is 2, we pass it through the dot, and then we get a post-test of 10. Whereas for intermediate uveitis, where the pretest probability increases, you can see that the post-test is increasing further, and in serpiginous-like choroiditis, it is increasing even more. So the bottom line is that your clinical picture is going to determine how useful is your test. Since the time is almost over, I'll just cover this very important point before I close the session. This is about testing for ANA and rheumatoid factor, which are probably the most commonly sent investigations in any uveitis patient. Now, how useful are these two tests? If we look at the prevalence of SLE in uveitis, it is only 0.7%, and it's the same for rheumatoid arthritis. Just 0.7% of posterior uveitis, 0.7 of anterior, and something like that. So with such a low prevalence of these diseases in uveitis patients, even if you get a positive ANA test, it means that your post-test probability is no more than 4.4% in a patient. So your positive test really has no relevance in a patient who does not have systemic signs of SLE. And similarly, if the patient is not having any systemic signs of rheumatoid arthritis, even a positive test is not going to tell you anything. In fact, if there is anything that you would want to carry from this talk, this is the point that I would want to convey, that we should not be testing for either ANA or rheumatoid factor unless there are systemic signs which are suggestive of one of these two diseases. Okay? I'll rush through this and I will summarize quickly that the patient is more important than the test. The predictive value, negative or positive, is more important than the sensitivity or specificity. We have understood how to understand pre-test probability through history, clinical signs, and prevalence. And what I did not discuss was when there is the pre-test probability is either very low or very high, then there is a concept of uncertainty, which is called as either false discovery or false omission. Thank you very much for your attention.
Thank you very much, sir, for introducing the concepts about how to investigate and why to investigate and what to look for in a test, and especially the Fagan's nomogram. I think we all should remember. Thank you so much. Dr. Malika has
One question, then there's one more talk. Do we have time? Okay. Excellent talk, Dr. Basu. What is your, protocol for starting anti-TB therapy? Do you really depend too much on the skin test or the TB Gold? Or
No. I first look at the, like I said, the patient is more important than the test. So with the patient having a picture which is suggestive of TB, and we have now very clear guidelines for TB, then the test is going to give you additional evidence. On the other hand, if the picture is very suggestive of TB, and this I see most commonly in cases of serpiginous like choroiditis, you also showed those cases. Even if the tests are negative, I go ahead and treat that patient with anti-TB therapy. So,
yeah, so that's very important.
yeah.
Clinical judgment is extremely important and much more important than tests.
Yeah. Thank you very much.
Thank you.
Now we'll go on to the next talk by Dr. Raj Kiran. Dr. Raj Kiran is a rheumatologist and he practices in Begumpet and he works very closely with all of us. So we'll hear about the treatment of uveitis and systemic immunosuppression.
Good evening, everyone. My name is Dr. Raj Kiran, and I'm the odd man out here. I'm a rheumatologist sitting with ophthalmologists. Thank you, Abhilasha and Dr. Somshila, Dr. Basu, for inviting me here to speak on this topic. So most of the time, like whenever we come across uveitis, whether it is anterior, posterior, intermediate, pan, so the first line of therapy is steroids. We all start with corticosteroids and we'll try to bring down the disease burden. But sometimes what happens is patients initially they respond well with steroids, and once you wean off or taper the steroids, there can be relapses. So the disease can come back, the inflammation may come back. So this is the time when we look at the other drugs, the non-steroid drugs, these immunosuppressives. So what happens is if the timely immunosuppressive is not introduced, so these, like you give steroids, reduce the dose, the relapse comes, again you increase the dose, you reduce the dose. So this sawtooth decline will cause chronic accumulation of the damage, and this cumulative damage will finally lead into loss of vision and lots of complications. So we all use corticosteroids as our first line defense, but there are lots of problems in chronic corticosteroid usage. So we, in our rheumatology practice, sometimes invariably we have to use steroid for a very, very long duration. We need to set a goal of long-term steroid usage. Usually the dose of 5 milligrams or less than 5 milligrams is considered as relatively okay, because the side effects, most commonly the cardiovascular side effects, the infective side effects, are slightly lesser when compared to the higher doses. So 5 milligrams or less than 5 milligrams is what we try to goal when we give a long-term steroid therapy. But at any given point of time, we always try to take patients off steroids and try to maintain them on immunosuppressives. So we also look at these complications like blood pressure fluctuations, blood sugar fluctuations, osteoporosis, cataracts. These are all should be kept in mind when our patients are on steroids. So immunosuppressive therapies are the defense which we use if we have to control and treat the patients for a very, very long term, because steroid is not a long-term recipe for these patients. So we have antimetabolites, calcineurin inhibitors, cytotoxic therapies, and biologics. Yeah. So we have these, we commonly use these drugs, methotrexate, azathioprine, mycophenolate, cyclosporin, cyclophosphamide. So each drug has its own place and specific diseases where we choose these drugs, and also specific patient population. Suppose a young female comes to us with an uveitis and who wants to conceive, definitely like methotrexate is not a choice, cyclophosphamide is not a choice, MMF we can't give if a woman is planning to conceive. So in those cases, drugs like azathioprine or cyclosporin would be our choice. So similarly, there are certain diseases like where we have an inflammatory arthritis with uveitis. So azathioprine doesn't work, mycophenolate doesn't work, cyclosporin doesn't work, methotrexate would be our choice. So we choose our DMARDs based upon the overall disease. Along with uveitis, what are the other areas which we wanted to target? If you look at most of the data, any of these immunosuppressive drugs works very similarly to control the ocular inflammation. So when we choose immunosuppressive drug, we need to do a pre-treatment screening. So like if we want to initiate methotrexate, complete blood picture, liver function test, at least a baseline chest X-ray, Hep B, Hep C screen is required. Similarly for azathioprine and MMF, other immunosuppressants, whichever you want to initiate. So we need to have a baseline screening, and we need to know what are all the baseline investigations. And most important, we also should keep in our mind like what would be the time of onset of action, because you should know it. What happens is when we start these drugs, patients, they come and tell after 1 month that there is not much improvement. So we need to know by ourselves, at least like if we start azathioprine, at least we have to expect results in 1.5 months or 2 years, sometimes up to 3 months, 6 months it might take. For drugs like methotrexate, usually it's after 4 weeks. And for a quicker action, we use drugs like mycophenolate, mofetil, and cyclophosphamide. So what if, I have chosen an immunosuppressive for my patient who has an uveitis, initially started on steroid, then I tapered on the steroid, I introduced methotrexate, and methotrexate started working after 4 weeks, and I have brought down on steroids. What if the methotrexate is not working, and when we have checked, still the eye is inflamed? In those conditions, what we need to see is our drug dose is adequate or not. If you are giving methotrexate 10 milligrams and if your patient is still flaring, the dose is not adequate. We can go up to 25 milligrams. Similarly, each drug has its own peak dose which we need to target, and the tolerating dose have to be given to that particular patient before changing the drug. So we can see like when can we use a combination therapies, like if methotrexate alone is not sufficient, sometimes we club methotrexate with mycophenolate or cyclosporin or tacrolimus. So we need to take these principles when we are giving the immunosuppressive therapy for a long term. So there are certain diseases where the uveitis would be the first presentation. Patient would not be exposed to any immunosuppressive prior. In those conditions, patients are treated with steroids initially, and simultaneously we introduce the second line drug. If we have a disease like Behçet or VKH, where we know OCP, where we know that a single course of steroid is not sufficient. So we simultaneously introduce a second line drug and we maintain that and we bring down the dose of steroids. And there are certain diseases where the patients are already on immunosuppressives. Say the patient is on methotrexate and the patient develops uveitis and sarcoid. So suppose in Behçet, the patient is on cyclosporin or azathioprine, patient develops uveitis. What to do in those cases? So that particular dose of immunosuppressive may not be adequate. So we generally with our colleague ophthalmologists, we try giving a course of steroids. So those patients might improve with that particular course of steroids, and we can still continue on those background immunosuppression. So, but if the patient keeps relapsing, we again increase the dose of immunosuppression or we add another drug. For example, if a B27 patient is on sulfasalazine or methotrexate, comes with uveitis, and if the patient is already on peak doses of methotrexate or sulfasalazine, we add an anti-TNF biologic drug. So as I said, methotrexate, we go up to 25 milligrams, and one thing should be kept in mind is it can cause lots of GI upset, and this GI upset may not start in the first few months. GI upset may start after once the cumulative dose of methotrexate is more than 1 gram. So it might start after 6 months or 1 year. The patient tells lots of nausea, vomiting, and they may not be able to tolerate methotrexate. Cytopenias are not very common, but transaminitis is common when we use combinations. Azathioprine, the most common problem is leukopenia. So we do TPMT monitoring, we used to do earlier, but nowadays the standardization of testing is a big question. So we closely monitor cell counts, and leukopenia is a big headache with azathioprine. And mycophenolate, yes, again the problem is the pill burden. We need to give at least 2 to 3 grams per day to have a good effect of mycophenolate. That's around 4 to 6 tablets per day, and each tablet would cost around 30 to 35 rupees. The cost and the pill burden is a problem with mycophenolate. Sometimes mycophenolate mofetil is not very well tolerated. In those cases, usually we prefer giving mycophenolate sodium. Cyclosporine, tacrolimus, they're an excellent drugs, but again, the nephrotoxicity is an issue. So these are good drugs if, again, the woman is planning for pregnancy, but again, we need to have a close watch about creatinine, potassium, hypertension, blood pressure. And it's also a good add-on drug, like if the patient is on methotrexate, non-responding, we can add cyclosporine or tacrolimus, and azathioprine, tacrolimus combinations also we do use. Cyclophosphamide, yeah, very like a sight-threatening disease. If the patient is having panuveitis, retinal inflammation, we prefer giving cyclophosphamide. Cyclophosphamide oral IV is mentioned, but usually we give IV intermittent pulses of cyclophosphamide. Again, the cell counts can drop when we give cyclophosphamide. Close monitoring is required. And coming to biologics, our choice in GIA uveitis is anti-TNF. Again, children, we don't like giving them steroids for quite a long time. Maybe initial dose of steroids we give, but immediately we try to switch them to anti-TNF drugs. Adalimumab is our preferred choice, and there's lots of data of adalimumab in uveitis. And the other drugs, infliximab, golimumab, when adalimumab fails, there are certain issues like immunogenicity problems with adalimumab. It may not work after some time. Then we choose another drug. And rituximab usually preferred for scleritis over uveitis. And IL-6 antagonists, these are second-line drugs. If anti-TNF doesn't work, patient has persistent uveitis, then we have to switch our action and we move to anti-IL-6. And like sight-threatening diseases, we can use IVIG where steroids are not recommended or steroids could not be given. And in pregnancy, yes, anti-TNF can be used, and steroids we can use, and drugs like azathioprine are preferred, and methotrexate no, MMF no, cyclophosphamide no. And to summarize, begin with steroids, but don't maintain with steroids. If you have to maintain, choose any of these immunosuppressive. Any of these drugs which I have told will work. Only thing is that just see what fits which patient is the important thing which we need to remember. And I thank all my ophthalmology colleagues, Somshila, Soumya, and Abhilasha, and most of them whom I have been working since last 10 years, and we have we had good camaraderie, we share good camaraderie, and we have been treating lots of these patients. And once again, ladies and gentlemen, thank you very much for your patient listening, and I am here for your questions. So as I said, if the patient is on methotrexate, first thing which we need to look is the patient is on 10 milligrams methotrexate or 20 mg. This methotrexate is a weekly dose.
No, assuming the dose is optimal.
Maximum.
Yes.
So assuming the dose is maximum, then they are called as inadequate responders. So if they are methotrexate inadequate responders, we add anti-TNF drug. It's an uveitis. The typical garden variety disease is the JIA uveitis or Angstmark B27 uveitis. If methotrexate alone is not working, so we can add anti-TNF drug. Adalimumab would be our choice, and and similarly for azathioprine 2, if it is not working, adding an anti-TNF would help. So suppose the patient is not affordable for anti-TNF. So in those cases, we can give methotrexate with mycophenolate combination can be used. Or sometimes we are not using nowadays, but methotrexate with azathioprine combination is also used in previously when in my graduation days for cases like myositis and other diseases where we used to combine methotrexate with azathioprine. So one thing when we use this combination therapies, what needs to be remembered is the toxicity goes high. So we might put our efforts on efficacy, but the toxicity also goes high. So we need to be quite careful. So in rheumatological diseases, we do like this. We go add on rather than replacing one drug with another thing.
Yes, thank you. Thank you very much.
Okay, Dr. Spurti has a question.
Hi, Dr. Rajkiran. I used to be a uveitis fellow in LV Prasad, and then I started working outside. So in LV Prasad, it was easy. We had good communication with the rheumatologist, either with the NIMS department or with you. So when I was in private practice, the uveitis cases were very less. But I got a case of an HLA-B27 recurrent anterior uveitis. So I had advised them to consult a rheumatologist, but that eye condition was just limited to anterior uveitis recurrent acute episodes and not more than 3 or 4 per year. So the episode was controlled by topical steroids, and I clearly mentioned in the file that for the eye condition, she does not require any immunosuppression. So they went and they consulted another ophthalmologist in Hyderabad, and from there they went to another rheumatologist. I saw that patient after 1 year, and she had definitely, I remember the face, so she definitely gained a lot of weight because of oral steroids. She received biologicals, and the recurrence was definitely less. And then when she came back to me, she had just stopped the systemic medication. So in HLA-B27, if the eye condition is controlled with steroids, do we really need immunosuppression and biologicals?
So your question is B22 positive recurrent
no
uveitis?
No other systemic complaints, only eye. For her, it was only the eye.
B27 positive recurrent uveitis, eye is quiescent, whether the patient requires immunosuppressive therapy or not.
Eye is having recurrences, but it is getting controlled with topicals.
With topicals. Maybe I am not sure whether how long you can use topicals in these kind of patients, because sometimes I get referrals from ophthalmologists, but if the patient does well on topicals, but the requirement for topicals is quite high.
No, these are just acute episodes getting controlled with topicals.
The question is whether you would treat her for the systemic manifestations of B27, which can be sacroiliitis, etc.
Yeah,
so,
why not?
But then if there is no clinical evidence, nor even maybe radiological evidence, would you still treat prophylactically is her question, which I don't think they would.
There is nothing like prophylactic therapy with B27 disease.
That's
because B27 patients, either they have disease or they do not have disease.
Because
if they do not have disease,
mentioned that she has recurrent episodes, but it is under control. So somehow that communication gap was there because I was not directly communicating.
I think Dr. Soumya, in next meeting or any other meeting, I think you can share one thing which we have prepared, myself and our LVP colleagues. So we have made a letter to rheumatologist. So that contains the message where the disease is active, inactive, anterior, posterior, intermediate, which area it is active, inactive, whether is there any requirement to increase the immunosuppression or maintain on same or reduce. I think the covering letter which we have designed is, we are doing a trial study on that.
So for someone like you is aware of uveitis?
So
that communication,
I can just intercede here. So the problem here is that you have to have a one-on-one dialogue with the rheumatologist. And then you have to sometimes find another rheumatologist. So we have learned the hard way, and that's why we have, so he put my name on top of the list, you saw that. People who trouble him, Somshila Murthy, so that's number one. So you have to find, once you find the correct rheumatologist who's also, I'm sure it's a very special skill and a very small niche area in rheumatology. So just like a retina specialist would not know about the cornea and vice versa. So it's probably something like that. So you have to find that niche and that person with whom you can communicate. Or even the rheumatologists will learn as we keep treating patients, so they will evolve with us. So it's a long-term partnerships if you find the right partner.
Okay, thank you. If there is time, I'll discuss outside.
Yeah, sure.
Yeah, in the interest of time, I think we have to close the UVI session because our senior pediatric faculty is waiting. So thank you so much for the great participation in this session, and we look forward to see you next year again. Thank you.
Thank you.
And thank you to all the speakers. Thank you, Dr. Rajkiran, for making it. Thank you.
Now, good afternoon, everybody. Sir. Sir, good afternoon, sir. I think
good afternoon. Yeah.
Sir is connected, no?
Can I share screen?
Connected, no?
Yeah, I am connected. Should I share screen?
Yes, sir. Now, in this strabismus, simplified strabismus session, Dr. Pradeep Sharma sir is on Zoom. Here we are going to meet sir. He is a internationally renowned strabismologist, and the session is named after, actually he has written a book on strabismus, Strabismus Simplified, and our session name is also same thing, Sir, I invite you to begin your talk, sir.
Just a minute. And share screen, just. Hello, is it? Yeah. So I would like to thank Dr. Raman, Dr. Rishi Swaroop for making it possible. And I would, at the first onset, I would like to share my misfortune that I am not able to be present physically in the city of fortune, that's Bhagyanagar. And I really congratulate you for holding this 8th Telangana Ophthalmic Society meeting. Here I would be presenting today the management of dissociated vertical deviations, which is a condition which is fraught with difficulties in management. As most of us know, it's a complex of dissociated deviations. The most common one is the vertical. So we are more familiar with the dissociated vertical deviations as DVD. And then the lesser components can be torsional and the horizontal component. How do we examine these cases? These are usually seen as a dissociated vertical updrift and a very slow recovery, which is different from a quick recovery from a version or movement which is there. So dissociated vertical deviation is a special form of strabismus characterized by spontaneous upward drift of the dissociating eye when the other eye is fixating a target and which recovers as a slow drifting redressal movement. It is a independent phenomenon, and although we are not having the time to talk about the etiopathogenesis, which is very interesting and complex, as you can see here, it may be latent. In the central picture, you can see behind the Spielmann occluder how the eye is drifting up. And when we bring a graded density filter bar over the dominant eye and increase the density of the filter, you will see that the eye comes back. So this is a light dependent phenomenon which is happening. Sometimes you may be having these cases coming up after the successful infantile ESO surgery in which the horizontal deviation was well corrected and the child comes with the updrift of the eye. So how do you manage these cases? If it is a photic, if it's an intermittent DVD, optical treatment may be done to make it photic, so that if the dominant eye can be blurred a little bit or the vision of the lesser eye can be improved by amblyopia therapy, you may convert an intermittent DVD into a phoric DVD. But if the condition is having a manifest DVD, which is there always visible, mostly it is a bilateral and asymmetrical, so it may be presenting more often in one of the eyes. What we need to see is if it's having associated inferior oblique overaction or not. Because if that is there, then the problem is simpler and you can manage it by doing an inferior oblique total anterior positioning. But if that is not there and superior oblique overactions are there, we have to manage it differently. And if oblique overactions, then use of superior rectus and the inferior rectus or the vertical recti. Now here is a case in which you can see there is a bilateral inferior oblique overaction. You can see the hypertropia in the adduction, and there is also a V pattern which is there. The Spielmann occluders on the side views is showing you the deflection of the eye, which is showing the DVD present in both the eyes. Now in such cases, as I said, we will be doing a oblique anterior positioning and total anterior positioning done. So what is done as a short video I'd like to share with you. So basically the inferior oblique is in the same way as you would do either a myoclone, but you insert at the insertion level. The sutures can be passed later on after disinsertion. Now here this step which is important is shown, that you will be the inferior oblique now in front of the inferior rectus, that as the 0 station or the +1, +2 or a +3 station. And here the inferior oblique is sutured in front of the inferior rectus insertion. So that is in short a very simple procedure, and as you can see post-operatively the inferior obliques are taking care of the DVD. So here there is a total anterior positioning which is causing an anti-elevation effect, which is taking care of it. But you have to be careful. This procedure can only be done and should only be done in the presence of an inferior oblique overaction. If it has been done unduly in a case in which there was no prior inferior oblique overaction and just for DVD one has done, it would cause an A pattern exotropia with a consequent superior oblique overactions like this girl shows. So such cases one should be very, very resistant in doing this inferior oblique AP. So how do we manage cases without oblique overactions? In such cases we would prefer to do either a superior rectus weakening, superior rectus recessions with or without Farden, or a newer procedure that we nowadays do is a Y-splitting of the superior rectus. And another procedure which comes handy is the inferior rectus plication, which is also an alternative. Now here there is a child having a DVD without inferior oblique overactions, as you can see here. And in this case, we can see that superior rectus recession 7 mm with Y split was done post-operatively. The results are really good on controlling it. Now here there is a video of the superior rectus recession with a Y split. Now you can see here the superior rectus has been hooked. The nasal side of the superior rectus intermuscular septum is separated, neatly dissected, and up to about 12 millimeters, the separation of on either side intermuscular septum is done. And then the superior rectus is split. This is similar to what you would do for the lateral rectus recession with Y split in cases of DRS. You should try to see that if it is split along the muscle fibers, the bleeding is going to be less. And be careful of the superior oblique tendon which may be underneath. And in these two ends, then the vicryl sutures are passed and the superior rectus is now disinserted. The other rectus is now, the sutures are being passed, the stump is getting secured, and the superior rectus is going to be disinserted. So now we need to mark it. Now 6.5 millimeter is the recession point, and we mark it both ways, 6.5 on either side. So it will be like 6.5 plus 6.5, that is 13, plus the width of the superior rectus, that is 8. So it will be about 21 millimeters of separation between the two ends of the Y split. This Y split is known to be working like a Farden operation, and in fact better than that, and that is why it is a nice procedure to take care of the superior rectus weakening done to take care of the DVDs. So here this is the 6.5 millimeter recession with a 20 to 22 millimeter Y split. And then the peritomy is being closed. These are the post-op 9 gazes of the same person showing you a good control. So is the plication of the inferior rectus, and here, as you all know, nowadays we are moving towards plication, whether it is in exotropia as the medial rectus or the case of here we will be doing the inferior rectus plication. Plication is a good procedure because we don't disinsert the muscle. So here, as you can see, the muscle is being hooked, and either side the intermuscular septum is dissected, and the check ligaments have also been. The point that we want to resect or plicate is the same. So we'll mark it here. It's, let's say it is a 4.5 or 5 millimeters, and the vicryl sutures are passed. Now this is the muscle bites which we have taken, and after this we pass it in the sclera just in front of the inferior rectus, and then back into the muscle. So this is like muscle, sclera and muscle, and figure of 8 bite which we have taken, and an iris repositor is placed in between, and the sutures are tightened. So this will take care of the tightening or the plication effect is there for inferior rectus or a medial rectus. So here DVT without inferior oblique overaction, preoperative, 9 gauges, and we had 10 PDs of PBUCT undercover. And after the IR plication, this is showing you the correction of the DVD and the upshoot is happening. We comparative evaluation of the inferior rectus plication versus a superior rectus recession in cases of DVDs without inferior oblique overactions. And this was a prospective study which was done in 21 patients, 29 eyes. And we found that the effect of IR plication was about 14.69 prism diopters compared to SR recession with a Y split of 17.46. Both these procedures are good. So to conclude, DVDs with inferior oblique overactions respond very well with inferior oblique total enteropositioning or IOAT because of the anti-elevation of the inferior oblique. But cases without inferior oblique overaction with DVD should not be the IOAT should not be done. Rather, we should be working on the vertical recti. So both the SR recession and IR plications had similar outcomes in the post-op correction and the minimal reversal after 3 months in cases of DVD without IOA in this study. The effect lasts much longer. The IR plication has the additional benefit of surgical ease, early reversibility, and minimal intraoperative risks, emphasizing the possible role of this procedure as a nice alternative even prior to the superior rectus. Superior rectus recession, of course, it is a good only prefer application in cases as having a superior in such cases. This is a DVD pre-op, as you can see here, and after these vertical recti being used, and this is corrected. So thank you all for this patient listening. If there are any questions, I would be happy to answer. Thank you.
Sir, one question, sir. What are the special clinical scenarios where you can do the Y split, sir? Yes, sir, Y split. Any special clinical scenario, DVD? I mean, how much is the deviation based on how many prism diopters of deviation, like that? Any? Oh, not connecting. Audiovisual problem. Sorry, not able to hear. Sir. Not audible, sir.
Yeah, are you muted? I'm not listening.
Mute
Nice
on,
to
sir.
see Dr. Ramesh, Dr. Raman, Dr. B.V. Rao, and Dr. Vidyavati after a long time.
Yeah, sir. Sir, sir, my question, what I asked you, sir, any specific prism
I am not
diopters
getting
of
the audio.
DVD? Babu, audio. All B.
Now I think you are okay. Now you are unmuted. Again you are muted. Dr. Raman, I think you are muted again. Now it's fine.
No, sir. Now okay, no, sir. Sir, my question is a bit of clarification. And how many prism diopters of DVD warrants SR Y split, sir? I mean, SR Y split.
Sorry, I didn't. SR Y split?
Yeah, sir.
What is the question?
Any indications, sir, like based on the deviation, how many prism diopters of deviation, DVD?
Okay. How much
Yeah.
deviations?
Yeah,
So
sir.
usually we do it in cases in which the prism bar undercover test, when we are measuring the DVD,
Yeah.
usually we would be measuring undercover and it should be 14 or 15 prism diopters or more, then we are doing this procedure. So either an SR recession with a Y split
Yes.
or an inferior rectus plication of 5.5 millimeter. But cases which have a lesser DVD, let's say 10 prism diopters,
Yes.
in that case, we have sometimes, like if the other eye, one eye we have done the IR plication of 5.5 millimeter and the other eye which is having an asymmetric lesser DVD,
Yeah.
in those cases a mini plication of has been used. Kenneth Wright's procedure of mini plication. So I've tried that. That works for about 10% of PBUCT. So you can combine a mini plication in one eye and an IR plication, full plication on the more severe eye.
Thank you, sir. Yeah. Thank you so much, sir. Next, I invite.
Thanks a lot for making it possible.
Sir,
Yeah,
thank you, sir. I invite Dr. B. Rao, sir. Again, Doyen. Yeah, madam, next. Sir will be speaking on oblique palsy. Again, a renowned strabismologist and running his own hospital, Shreyas Eye Care Center, a pediatric ophthalmology center.
Thank you, Dr. Raman, for inviting me to be a part of this session at the 8th TOSCON conference. So I'm going to speak on how you diagnose and manage a case of superior oblique palsy. Now, superior oblique palsy is the most common cause, it's most common vertical deviation which you see in children. Now, if you look at the superior oblique muscle is a unique muscle which has got three parts. The one is the orbital part, and then the one which gets redirected from the trochlea and gets inserted underneath the superior rectus, which is a fan portion, and this is a cord portion. And this is the actual muscle behind. So normally, because of a musculofacial abnormality with the superior oblique muscle, the muscle tends to be loose sometimes, or sometimes it gets inserted nasally, or sometimes it's absent and causes a decreased function of the superior oblique and creates a vertical deviation. As said by Belchowski, it's half as common as the sixth nerve palsy, what you see. So for any vertical deviation in a child, unless proved otherwise, it's a superior oblique palsy. And usually it's a congenital one because of an abnormality with the superior oblique muscle, not a neurogenic one. The neurogenic ones are usually seen after trauma, after head injury, or after an ischemic mononeuropathy in older individuals. Now, when you come to the workup of a patient who's got a vertical deviation, you need to look at the history, old photographs to see if there is any head tilt. Whenever you have a vertical deviation, the brain tends to kind of compensate by tilting the head towards the opposite side to make the retinal meridians normal and to get out of the double vision. So that head tilt which is there, if it's permanent, long-standing head tilt in a child, would give rise to an abnormality on one side, which is facial asymmetry. And facial asymmetry, which if it starts, it generally stays permanent. It also causes a bony changes in the midface because of a long-standing head tilt. So head tilt observation is important. Look at the old photographs. And then work up, as usual, what you work up for any strabismus patient by doing a prism bar cover test, and in 9 different gazes, because superior oblique muscle has got functions in different gazes. Now, for congenital superior oblique palsy, these are the things which you really look for. A big head tilt. Generally, they don't have any double vision because the brain tends to kind of compensate by tilting the head towards one side, and they have a facial asymmetry, old photographic documentation, and usually a lax tendon. Because of the lax tendon, the function of superior oblique is less, and that causes the inferior oblique to overact, and it gets a vertical deviation. And then you tilt one to head towards one side to come out of the vertical deviation. And usually they tend to have large vertical deviations. Amplitudes are large. Initially, there may be a small vertical deviation, but when you start checking, when you start making the head straight, and then you do an alternate cover test, you keep building the vertical deviation. So they have a large vertical amplitudes, so the vertical deviations are masked actually. Unless you kind of make the head straight, then you do an alternate cover test, you start building the deviation in the primary position. Now, a typical patient, how it looks like, you see this child. This child has a left hyper when she looks to the left side, and you see a right inferior oblique overaction and a right superior oblique underaction. It's a classical case of a superior oblique palsy. And when she looks onto the other side, when she looks here, the underaction of the superior oblique, and when she goes onto the other side, you see there's none actually. So on one side you see hypertropia, on the other side you don't see any hypertropia. So that's the second part of the Belchowski's head tilt, Parkes 3 steps test. Parkes 3 steps test is Whether first step 1 is hypertropia, which eye is hyper. Step 2 is which side is the hyper more. Okay? And step 3 is the Belchowski's head tilt test. Just the Park 3-step test, which will tell you which muscle is involved. Okay? Now you do a head tilt here, and you see that on tilting the head to the right side, there's a larger hyper. That's because the superior oblique is weak, as a result of which the superior rectus tends to do more work and it elevates. It compensates for the incyclotorsion of the superior oblique. So when the superior oblique is not doing the incyclotorsion, when you tilt the head to the right side, the superior rectus tries to compensate for the intorsion by doing more work. But superior rectus is an elevator primarily. So it pulls the eye more up. So you get a larger vertical when you do a head tilt. Now on head tilt to the left side, you see none actually. So this is a classic case of a superior oblique palsy Park 3-step test. Okay? Now you see here a facial asymmetry here. Sorry, this is a head tilt. Now any child who is walking into your clinic like this with a head tilt towards one side, most common cause is a vertical muscle abnormality, a cyclovertical muscle abnormality. That's the most common cause, and the most common is superior oblique weakness, palsy. The second common cause would be orthopedic torticollis, a sternocleidomastoid problem on one side and giving rise to a tilt. So how do you differentiate whether it is a muscle torticollis or an orthopedic torticollis? You patch one eye. If you patch one eye, if it's because of a muscle problem, it will go away generally in children. But in long-standing cases, even if you patch, sometimes the head tilt remains. But in a child like this, if you patch the eye, patch one eye, the head tilt generally goes away. That's one of the tests to kind of know whether it is a eye muscle torticollis or an orthopedic torticollis. And now you see here, there's a facial asymmetry here, there's a facial fullness here, there's a contraction of the face there, mid-face. So this is, unless proved otherwise, this is a right hypertropia, tilting the head towards the left side to compensate for the right hyper, and usually it's a right superior oblique palsy. Now, yeah, the side one is, this is just a temporary way of, kind of rough way of assessing for the facial asymmetry. When you put two scales on the lateral canthus and at the angle of the mouth, they should be parallel to each other. They should not get contracted or towards each other closer. The other way around is to do an X-ray of the mid-face, and you can see a bony abnormality, which is a permanent change. Sometimes it happens on long-standing head tilts. Generally, the head tilts start appearing when the style child starts walking. Though you have a congenital anomaly, it doesn't get manifest until the child starts walking, because that's the time when the child starts adopting because of the abnormality in the vertical movements, and also when you start walking, the orientation of the retinal meridians will be different, so they'll tilt to balance it. Now, this is a key intraoperative test, a superior oblique traction test. This will tell you whether this muscle is really lax or it's normal or tight. And this test will also tell you whether you should go and operate on the superior oblique muscle. Generally, in superior oblique palsy patients, we do not operate the superior oblique muscle unless it is lax, because you're going to create a Brown syndrome. Now, if you look at this, the photograph here, normally when you elevate the eye into adduction, about 1/3 of the cornea tends to go under the lid. Now, if you look on this side, if it's a lax tendon, almost all of the cornea goes kind of not visible at all, okay, in the picture there. But when you do a traction test, now when you do a traction test, you need to kind of retropulse, push the globe inside into the orbit and then do a traction test, not proptose the globe. If you proptose the globe, you're putting the vertical recti on stretch. If you retropulse the globe, then you're testing for actually the oblique muscles, okay? So that's a key thing between a force reduction test and a traction test for obliques, okay? Now you see that I've retropulsed, and then I'm holding the two forceps, and I can feel the tendon there. That's inferior oblique. Now this is superior oblique. There's a laxity there. So you see that almost I can actually feel the tendon, but it's lax, as opposed to the other maneuver when I did. When I did downward and laterally, that's for the inferior oblique, but when I'm doing for the superior oblique, into this elevation into adduction and then go temporally, okay? Now you see again there. That's for the inferior oblique traction test. Inferior oblique is tight actually there. And that's the superior oblique, okay? That's a lax superior oblique, okay? Sometimes you may not even feel the tendon. So that's very important, because that will tell you whether you need to kind of go and tackle the superior oblique or not. So these are some of the anomalies which can cause a superior oblique palsy. A lax tendon, a nasal insertion, a posterior tenonal insertion, and sometimes an absent tendon itself. Now coming to the management part, there are two things which are here in this slide. Usually it's a surgery for a large angle. If it's a smaller angle, generally smaller angles are the acquired ones, which are post-traumatic or post-ischemic. Those can be managed by prisms, giving vertical prisms in the glasses, or wait for natural recovery. But if it's a larger angle, a big head tilt, then they will require surgery. Now, this is the NAPS classification, which you all would be knowing it, because the superior oblique palsy is about, there are 7 types of superior oblique palsy. Basically, all these types have been classified based on the amount of deviation in different fields of gazes. The longer the duration of any deviation, it will spread into different gazes. Because it's a vertical muscle, because it's an oblique muscle, it's got 3 functions, it works in the side gazes. As the spread of comitance increases, the field of deviation spreads into different gazes, and then that causes problem. And that causes all these types which will go across. Now, this is a type 1 palsy, where you have a hypertropia with an overacting inferior oblique, left inferior oblique overacting there. You see here, inferior oblique overaction. A simple inferior oblique surgery, inferior oblique myectomy or inferior oblique recession, whichever you are comfortable doing it, you could do that. You weaken the inferior oblique and you balance it, the hypertropia goes away. These children, the type 1, have a hypertropia which could be ranging between 5 to 15 prism diopters. And this 5 to 15 prism diopters of hypertropia can be taken care by doing a inferior oblique myectomy. So I'm not going into the videos. Okay, yeah. Now, we'll just go to, now you see this is a tucking of the tendon, where it's a lax tendon, a loose tendon which was seen there, and that loose tendon is bunched up on the forceps, and then we do a tuck of the tendon by using an non-absorbable 5-0 ethibond. Now, after doing a superior oblique strengthening, when you do a test, when you elevate the eye into adduction, normally you should feel a tug, like a Brown's, where the eye should just elevate, up to a horizontal line between the lateral canthus and the caruncle. It shouldn't go, if it goes up to there and stops, and that's what is the tightness you require. You don't want more than that. If you create too much of tightness in the superior oblique by strengthening it, then you'll create a Brown syndrome, where you have a limitation of elevation. You have a problem down gaze, you have a problem up gaze, and it becomes really difficult to manage. Now, this is the type 3 ones. The type 2 was the one where there was underaction of the superior oblique because of a loose superior oblique. So we tucked the superior oblique, strengthened it, and balanced it. Okay. Now, type 3 is you have in all 3 fields, in the dextroversion, dextrodepression, and in that field, in the right field. Okay. So here, if it's beyond 15 prism diopters, you will require 2 muscles. You do inferior oblique weakening, or you do a contralateral inferior rectus to balance it. And if it's a lax tendon, you tighten the tendon. Okay. Now you see here, right hypertropia, underaction of the superior oblique, and this is after the inferior oblique myectomy and after the tuck there. Okay, so the two muscle surgery, because the deviation was more than 15 prism diopters, so single muscle will not take care. Superior oblique tuck will definitely improve the function of the superior oblique, but it may not be total improvement, but it does improve. Now this is a type 4 superior oblique palsy, if you see this here. Large left hyper, underaction of the superior oblique here, overaction of the superior oblique here. Now this is a type 4 superior oblique palsy because of a long-standing hypertropia. The superior rectus will become tight, and as the eye is tending to go down into the left levo depression, a falsely overacting superior oblique is shown here. Some people have weakened the superior oblique on this side, thinking that this is a superior oblique overaction, but this is not a true superior oblique overaction. This is all because of a tight superior rectus here, because of type 4 superior oblique palsy. Here what you need to do is an inferior oblique surgery and a superior rectus weakening. That will take care. Don't weaken the contralateral superior oblique, otherwise you'll create a iatrogenic superior oblique palsy on the other side. So from one superior oblique palsy, you would have created a bilateral ones. So this, originally the Phil Knapp, actually when he described this type 4, he weakened the superior oblique on the other side and he landed in problem. Then he came to know this is all because of a tight superior rectus on the same side. So type 4 superior oblique palsy you should remember. The type 5 is again on the inferior gaze. Now coming to bilateral superior oblique palsy, the post-traumatic ones after aerotraffic accident, you see not much of a hypertropia here, not much of a hypertropia here, but on the down gaze you have a V pattern, EZO in the down gaze, and an excyclotorsion here. Severe excyclotorsion because of both the superior obliques getting paralyzed because of the fourth nerve weakness. Now, when both superior obliques get weaker, you won't get much of hypertropia because they balance off. The verticals get balanced off usually. You will see a lot of excyclotorsion. You will see crisscross diplopia like this. And these kind of cases generally will require a torsional surgery where we do a Harada-Ito procedure, where we strengthen selectively the superior oblique muscle, anterior transpose the superior oblique, tighten the anterior fibers like this here. So we split the superior oblique tendon and pull the anterior 1/3 of the tendon anterior and temporally and suture it about 8 millimeters behind the superior lateral rectus. So that's the type 4, that's the bilateral superior oblique palsy. Now, as I told you, the Brown syndrome, sometimes you may have a traumatic injury to the trochlea and also you have a superior oblique palsy. An injury to the trochlea will cause limitation of the elevation, that is called the Brown's kind of a thing, and superior oblique palsy. So this is called the type 6 or type 7 ones, what we call as a canine tooth syndrome or a dog bite syndrome to the trochlear area. And here you need to kind of, in this kind of a scenario, you need to open up the superior oblique muscle, release all the adhesions, and then weaken the inferior oblique to balance it. Now, one more case. Now, not all patients of superior oblique palsy will present with hypertropia. You can also get a case with the hypotropia. Means the affected eye is the fixating eye. Usually, the fixating eye is the unaffected eye, and you get a hypertropia. But sometimes the fixating eye is the affected eye. So when the affected eye is the fixating eye, you'll get hypotropia, like you see here. This child has got a head posture, right hypertropia here, and So on tilting the head to the right side and tilting the head to the left side, now you see here, this photograph you see fixing, this is how the child presented, left hypotropia, which is worse in the left gaze, overacting superior oblique, overacting inferior oblique, underacting superior oblique, underacting superior oblique and overacting inferior oblique. And this side it's normal. And this child also has a flattening of the forehead. So this is a craniosynostosis, plagiocephaly, premature fusion of the coronal sutures giving rise to a plagiocephaly, flatness on the forehead with a superior oblique weakness, where there's a desagitation of the trochlea giving rise to a weakness of the superior oblique. And sometimes these patients can present with the fixing with the affected eye. So you'll get a hypotropia. So don't get confused. Again, go by Park 3-step test and you get the muscle in. Okay, that's how it is. And then this is after the surgery. You see that we did an inferior oblique myectomy and a superior oblique tuck, and the improved functions of the superior oblique balanced all on the 3 sides is balanced here, and the pre and post kind of photographs there. Pre and post photographs you can see here. Pretty gratifying result for this patient. This patient also underwent a craniofacial surgery. Sometimes we advise craniofacial surgery to be done first and then do a muscle surgery. Okay, so this patient underwent a craniofacial surgery and then subsequently we did a eye muscle surgery on this patient. So the take-home message is tuck the superior oblique only when it is lax. And how do you know it's lax? You do a traction test. When you keep doing the traction test multiple times, compare it with other eye, you will know whether it is lax or not, and then you open and see. Traumatic ones, the acquired ones, wait for 6 months to recover. If they don't recover, if it's a micro squint, you balance it by giving prisms, but sometimes you can do a mini surgery on these patients. And this is again a small angle usually seen in the elderly people, the microvascular. And the conclusion, weakening the inferior oblique as the first surgery is the best one. Tuck only lax tendons, weaken the ipsilateral superior rectus for class 4 superior oblique palsy, other side yoke inferior rectus for larger deviation, and horizontal surgery if needed. Sometimes you may have horizontal deviation also mixed with the vertical deviation, so you need to do all at one time. So superior oblique muscle complex is not forgiving, so you should approach it with care. Thank you very much for a patient hearing.
Thank you, Dr. Rao. It was an excellent description of superior oblique palsies with multiple cases. Any questions from the audience? Okay, if there are no, we'll go to the next speaker.
Just a bit out of turn, I am here as a professor and teacher of Dr. Raman earlier. I have known Dr. Raman from his postgraduate days, and for the last 16 years, he has been in charge of the strabismus and pediatric ophthalmology department at Sarojini. And as a professor now, he's dealing with complex strabismus, and he has found some simple solutions which he wants to share with you all. Dr. Raman.
Thank you, madam, for kind words. Now, my talk is on complex strabismus forms, yet a simple solution, that is in the form of muscle transplantation surgery. So actually, muscle transplantation surgery is surgery. It is a newly emerging surgical modality where we use the resected muscle piece and transplant it onto the recessing muscle so that the recessing muscle is lengthened, and that lengthened recessed muscle will enhance the recession effect. So that is a key behind the surgical principle of muscle transplantation. So here I can show you schematically about the muscle transplantation. And usually what happens now, especially in a concomitant form of strabismus of large deviation, like more than 60-65 prism diopters of deviation, where generally we do a recession resection combination of surgery, and in case of esotropia, a biomedial resection, depending on the clinical type, we resort onto by two muscles. But when the deviation is increased, I mean like more than 60 prism diopters, sometimes we see the case of large deviation going up to 65, 70, 80, sometimes 90 prism diopters. In those cases, they warrant the multiple surgeries and multiple number of muscles have to be involved to correct the deviation. So with the help of the true muscle transplantation surgery, we can go up to even up to 80, 90 prism diopters of deviation. We can adjust with two muscle surgery only. That is the intention of doing it. Next, I will play the surgery here, a small snippet video. So here now, this is done for a large angle exotropia. So Pfizer Edband suture is used here after isolating the recessing LR muscle. Now the resecting muscle is identified and 5060 Weichel suture is applied. Generally, I do the painting on the surface, both the proximal end and the distal end. Once the two Weichel sutures are applied, we cut the tendon, and then at the desired amount of the resection, whatever we planned, we cut the muscle piece, and the resection is completed as usual, like any resection procedure. And once the transplanted piece of muscle is put into the BSS solution, and then it is transplanted onto the recessing muscle. So the distal end of the resected piece of muscle is attached with the Pfizer Edband suture, which is already pre-placed, and then the distal, the proximal sutures, 60 Weichel sutures used for the scleral fixation. So this, once we do the transplantation surgery, the resected piece of muscle acts as a biological spacer, so that the recessed muscle length is increased. At the same time, the functionality of that recessed muscle is not compromised. Otherwise, what happens if you go for supramarginal resections, especially in concomitant form of deviations like heavy eye syndrome and other forms. So there is a chance of patient landing in globe retraction, and sometimes they may produce lead signs, and sometimes they may land up in incompetence. Okay, those complications can be avoided. Now I share my experience with where I used muscle transplantation surgery for 3 different clinical scenarios. First scenario is in adult onset exotropia, where the patient of 27-year-old boy presented to us with, you can notice here the pictures when he was at the age of 7 years, you can see, and at the age of 27 years, you can see him. And at the age of 31 years, then he came with the large angle exotropia. In between, for more than 1 year, he suffered with intermittent exotropia and then on and off diplopia. Then further, it has become a manifest deviation, and he was continuously suffering with the diplopia and compensated head posture occasionally. So he was using the spectacles, and on orthoptic evaluation, the patient, there was a true alternation was there, and then the movements were full. And then on diplopia charting, you can notice here the patient was having an uncrossed diplopia. Again, this is a paradox. Actually, in exotropia, we find the patient landing with crossed diplopia. But here, this patient has shown uncrossed diplopia, which is a paradoxical form again. So these are the peculiar features of this case. So this case was taken for strabismus correction by doing muscle transplantation surgery. You can see here. So we did 11 millimeters of LR resection combined with 7 millimeters of MR resection with muscle transplantation. So postoperatively, you can see at the end of the week, we achieved orthotropia. I'll show you once again. At the end of 1 month, patient is quite comfortable and achieved orthotropia and relieved of the diplopia. So now the second case scenario. Here this gentleman, he was a known case of lateral rectus palsy, left eye, and previously also he had bilateral LR palsy, but later he recovered, and recently 2 years back again he has come with the left eye LR palsy, which has not recovered. And on clinical examination, you can notice here he has a uncrossed diplopia. And when you look at the ocular motility examination here, you can find there is a huge deviation in the left eye, and which has never recovered, almost 75 prism diopters of the deviation. And best corrected visual acuity in both eyes is in the right eye 6/6 and in the left eye 6/9. And you can see the ocular motility analysis here. He has -2 abduction limitation in levo position, both levo up, down and levo. At the same time, there is a large deviation. So these are the intra-op pictures of the same patient where we did the MR resection of 7 millimeters and LR resection of 9 millimeters with muscle transplantation to the MR muscle. Here, the peculiarity of this case is that in this patient presented late with a large EZO deviation of 75 to 80 prism diopters and abduction limitation of -2. And the peculiar thing is eyeball is moving beyond the midline. Okay. Generally, lateral rectus when we manage, clearly suppose there is a small deviation, we go on to do the MR resection. And sometimes if the deviation is a moderate deviation like 50 or 55 prism diopters, we go along with the modified Nishida. But here this is a peculiar situation. Generally, in the lateral rectus palsy, the amount of the deviation and the motility, they are proportionate. But here in this case, there is a large deviation, but at the same time, the limitation is actually minimal, I mean -2 limitation. So here the situation is, I have to go for R&R procedure. Okay, so not the transposition procedure. Generally, we do the transposition procedures when the deviation is larger, like more than 60 prism diopters. We go for a full tendon VRT or a partial tendon VRT. But here it is a different clinical scenario. So I planned for a transplantation surgery. So it has resulted in, we achieved orthotropia postoperatively and patient is stable. Now my third scenario is that a 25-year-old female lady, she is a nurse working in Sholapur, and she was a known case of, diagnosed case of DRS. Here the peculiar feature is The affected eye is the left eye, in fact, but there was a large angle ESO deviation, almost close to 90 prism diopters in the right eye. So why? Because the right eye visual acuity was not good in CF 1 meter like that, the vision, and left eye vision was 6.6. So here what happened, no? This is a case of DRS, type 1 DRS of the left eye. Here what has happened, no? So since there is a poor visual acuity in the right eye and good visual acuity in the left eye, so left eye was preferred for fixation always. Since her early childhood, I mean since after birth you can take it as. So then what happened, the right eye has gone into almost like a near to fixed status, okay. And there was a strabismic amblyopia is added even to the right eye. So here you can notice here the ocular motility in the left eye. You can see that there is a abduction limitation, both levo up and levo down position. And on adduction, clearly you can notice here there is a palpebral fissure changes. I mean there is a narrowing of the palpebral fissure. So here I prefer to operate the right eye because right eye was problematic for the patient. All the time, you notice the clinical pictures, so all the time. And here another peculiar feature is she has left face turn. So I operated this patient with muscle transplantation surgery. So almost 7 millimeters of MR resection combined with 9.5 millimeters of LR resection and muscle transplantation was done. And postoperatively you can notice we achieved orthotropia, and postoperatively she is quite stable throughout our follow-up. But there is slight, 20 to 25 prism diopters of undercorrection has resulted, but otherwise movements are full. So patient is quite happy cosmetically. But anyway, she was already a known case of strabismic amblyopia. So we cannot improve the vision now at this present status. But cosmetically we achieved a reasonably good correction and patient is happy. So with this I conclude that the muscle transplantation surgery is not only in concomitant forms of deviations, but I think in special situations we can utilize this surgery in other like these clinical situations, and where we can definitely achieve orthotropia and we can achieve the stable results. Thank you for the opportunity. Thank you for patiently listening. Thank you, sir. Now I invite Dr. Ramesh. Today only he won Rustom Ranji Oration Award. I feel honored to invite.
See you, if at all tomorrow, I'm not sure.
So this is the last presentation. I think I thought I'll spice it up a bit. Strabismus is a dry topic. What I've chosen is I've chosen some topics, some cases, so that we can. I do not have any financial disclosure for this particular presentation, but I am a scientific advisor for Revital Vision therapy for amblyopia. So these are my objectives. I just title it as Spice It Up. You can see the objectives. It's just the cases of which are different. Just spice it up is the topic. So the first one is superior oblique. Dr. Rao already said, whenever these muscles are very lax, you have to tuck this muscle. How to tuck the muscle? Do you use any kind of measurement, or do you use any scale, or what you use? This is where we have made this kind of video. You can see. Can you have the volume? Do you have it? I've connected here. So we just use this namaste sign for the superior oblique palsy. When you do this namaste, you try to tuck the muscle. It's a simple tool. There is no measurement or anything is required. Whatever that laxity, you need to just kind of correct it. With that,